everybody. Welcome back to another episode of the Fearcast. This is the podcast dedicated to OCD and anxiety spectrum disorders, and getting your life back. I'm your host, Kevin Foss, and I'm a licensed therapist specializing in OCD and anxiety disorders. This is a podcast where you get to send me questions about OCD and anxiety and recovery and treatment and how to help your friend and how to help your loved one deal with and face and fight and overcome their anxieties. So if you're new to this, you can send me a question if you have a question. If you have a question, I suppose, go over to fearcastpodcast.com and you can send me a question there. You can also send me a question over at Instagram. I am Fearcast Podcast over at Instagram. You can send me a question there as well. You can also send me an audio question. You can send it over by sending me a DM at Fearcast Podcast. Just send me a DM there and record your voice in that DM. You can also send me your question if you record it on your phone and email it to questions at fearcastpodcast.com. Anyhow you get the question to me, I will read it, consider it, listen to it, and likely put it up on a future episode. For today's episode, I wanted to put something up in anticipation for Mother's Day. So Mother's Day is going to be about a week out from the release of this episode, but Mother's Day is it's mixed for a lot of people. It can be a wonderful day to celebrate moms. It's a wonderful day to celebrate your spouse. A wonderful day to celebrate just what it means to be a mom and how much work goes into that, how much reward comes from that. It can be a mixed day for some who struggle to have kids. For moms who want to be moms, or people who are striving and struggling to earn that title or to get that title. And it's a hard day for some. And for some, it's also a hard day because, they think they're supposed to feel something or be something or, have an air or an attitude about something, about being a mom. And yet OCD and postpartum OCD and postpartum obsessions steal that from them. And that's what this episode is all about. So today I have Jonathan Abramowitz on, or Dr. Jonathan Abramowitz on, to talk about his work in postpartum OCD and what it is. We're going to talk about what it is, how it works, what treatment for it looks like, and hopefully give folks some hope and some optimism and some kind of a roadmap on what treatment can look like and how you can overcome those obsessions and kind of learn to be the best mom you can. And also say this, to be the best dad you can and have these obsessions at the same time. So before I get into that, I'll tell you a little bit about Dr. Abramowitz in just a moment. And by the way, if you want to hear more from Dr. Abramowitz, go check out our previous Fearcast episode. I believe it was, 209? Let's see here. I had this up just a moment ago. Abramowitz Fearcast. I'm doing this on the fly. It is episode 209. Go check it out if you want to hear more about him and his book, Living Well with OCD. So go check that out. But this week has been, just before I get into it, there's been a lot on my mind about how we get information and how we can get trustworthy information. There's a lot to be said, a lot of talk in the past bunch of years about fake news. A lot of, the reality, it's tough to find information that we can trust at times. And especially when you're looking for information, looking to get answers or hope or encouragement in any way that you can, you're going to go to the internet and you're going to try to find something. You're going to, let's say it has nothing to do with anxiety. Let's just say you're watching the news or you see something on Reddit or somebody sends you something, you cross something on Facebook and you read something, you go, that's crazy, or that's scary, or that's upsetting, or that's, demeaning in some cases, or whatever it might be. And you can wonder, can I trust the information that I put out there? And I'd say that about, OCD therapists and information that you might find, right? There's a lot of podcasts. There's a lot of people spouting a lot of stuff, myself included in this. So how do you know that you can trust information that I'm putting out, trust information that others are putting out? Because we're kind of, for the most part, a lot of us are saying the same things, but we might be saying it in slightly different ways. So how do you know how much you can trust with that, right? So, it got me thinking about actually got me thinking about, those like toothpaste commercials or something like that, where they're like, 9 out of 10 dentists suggest or recommend this or whatever it might be, right? It's like, well, what about that like one like rogue person where they're like, you need to brush your teeth, whale spit, that's the best. Like, I don't know what they're going to put out there, right? But they're going to have this consensus of like 9 dentists, and then there's like one rogue weirdo over there who's suggesting something completely off the wall, right? Same thing goes for news. Sometimes you're going to have a story that's out there, and 9 out of 10 outlets that you go read kind of say the same thing, and then there's that one that's super left field, it's super weird, and it has this whole different spin on things that seems very confusing and odd or scary. And we go, well, what do we do with that, right? I think it's important, like as we're kind of filtering through the world around us, what a lot of times what we want to do is look for that consensus. What is the vast majority of people saying and doing? And we can kind of glean from that's probably most likely the most accurate, the most correct way to view it, perceive it, move forward with it, and act on it, however you might want to say that, right? We kind of talk about this with scrupulosity. We'll talk about this as the 80-20 rule. The 80-20 rule is like within scrupulosity, let's say it's, within a church, right? You go like, I don't know how much I'm supposed to pray. I don't know what I'm supposed to do in this situation. And we go with the 80-20, and it goes like this. It's like, what does 80% of the people within your congregation or your, religious system or group do or say or believe about something? And we're going to kind of go with that. The vast majority, right? Because there's going to be some people at 20% who are going to be different. There's going to be 20% at the higher end and 20% at the lower end. So, they're going to be doing way too much, way too little of something. So what we're trying to do is when we're in doubt, when we're questioning things, we want to go with the vast majority of what people are saying. Now, it might mean that, there could be something to learn from the 10% on either side. But if you're looking for, what's probably the most accurate bit of information and the most trustworthy thing, a good rule of thumb is to go with what, 80%, the vast majority of people are saying. And I'll say that as far as OCD treatment and anxiety treatment goes. There might be, you might listen to 10 podcasts, and there might be 9 of us or 8 of us maybe who are going to kind of say the same kind of thing, right? We're going to talk about exposure and response prevention. We're going to talk about, challenging thoughts. We're going to talk about, accepting our feelings and our thoughts and making space for them and having compassion for ourselves as ways to deal with our anxiety. There might be someone out there who's going to have a very left field approach. Now, as you're moving forward, if you're just gathering information, it's wise to go with what the vast majority of people are saying in that. Now, that doesn't always count for when you are working with a therapist, and that therapist who knows you, who you trust, who they trust you, and you're building this relationship together. They might make a recommendation. They might make a recommendation for something that might be a little off. And you can ask them about that. Like, what's their logic, their reason, why they're recommending that. But they're going to be saying that based on you and the relationship they have and what they know about you, right? If you're out there just kind of looking for information, I'd really recommend you look for, like, what is the average person, the average podcast or therapist saying? And we want to try to go with that and kind of filter out some of those like extraneous things that can be confusing or really left field. It's kind of like, the vast majority of us therapists are going to say, OCD and anxiety disorders are kind of chronic disorders, meaning they're going to be their life things, lifelong things. Now, that doesn't mean they are debilitating. It doesn't mean that they are going to be robbing you of having a full and successful and enjoyable and meaningful life. It means that this is the way brains work. And this is for someone with OCD, that's the way that their brain is perceiving the world around them. And there's, a lot of habits and a lot of reinforcement built into that. So there's a lot of stuff going on, but that habit and the way that someone thinks is going to show up from time to time. So It's about building an awareness and building in better tools and better coping mechanisms to deal with the world around them, right? There are going to be some people out there who are going to say OCD is overcomable in that you can eliminate it and you can never have obsessions again. I become weary of those folks because I believe they're selling something that isn't true. It feels like it's kind of like saying, hey, you can take this pill and you're never going to get sick again. You're never going to get the flu again, right? Or you're never going to get a cough or a cold or something like that ever again. It's unrealistic. And with that, you might say, well, that's crazy. But part of our brain, I'll be honest, part of our brain goes, really? So I just take that pill, I never have to get sick again? I mean, it sounds kind of nice. And we can start to entertain them. But there's that story of if it's too good to be true, it might not be. And I think that can also come, and that comes in both the tails, right? If it seems too good to be true, it might not be. If it seems too catastrophic and too terrible and too awful and too horrible, that might not be true either. So what I'm saying is I'm cautioning everybody to be kind of careful consumers as they're taking in information. And I say all of this not as a way to try to undermine Dr. Abramowitz, because it has nothing to do with my conversation. I recorded this conversation with Dr. Abramowitz a couple weeks ago, but I've seen a little bit of that lately, where there's just been this grabbing onto one source, one outlet, one line of something, and extrapolating something a lot broader from that. And OCD obsessions are primed for that. You're going to see that one thing go zoom and focus in on that one thing. And it can really take you into tailspin. So if you have questions or concerns about it, I think a really good way to think about that or to challenge that is to take that bit of information and take it to the most logical, reasonable, down-to-earth person that you know and say, hey, friend, so, I've got this thought and I read this thing or I heard this on the news and, it makes me feel or think this way and I want to do that. What do you think? And see what they have to say. Are they going to agree with you that you should be bent out of shape, that you should follow down that path, that you should be freaked out or angry or upset or sad? Or are they going to say, man, that sounds off. That doesn't sound quite right. So we can test that. Now, I know that's going to sound like reassurance seeking to a lot of people, but there's also something called reality testing where, sometimes our brain is going to take us to left field, and it's important to bring that to light and to ask someone, hey, what do you think? And these can be one and done reassurances or one and done questions where we're just trying to get a little bit more information so we can move forward. And again, the moving forward is key. The reassurance is ask the question, and then keep asking the question and ask it in a different way and ask to a different outlet. So it's about, we're trying to just gather a little bits of information and then moving forward as best we can without getting sucked into one particular statement or comment or idea. All right. That is my sermon at the top of this. So let me tell you a little bit about Dr. Abramowitz, and then let's get into that interview. So Dr. Jonathan Abramowitz is a professor of psychology and neuroscience and research professor of psychiatry at University of North Carolina at Chapel Hill. He's also director of UNC's Clinical Psychology PhD training program. Dr. Abramowitz conducts research on OCD and other anxiety-related disorders and has published over 20 books and 300 peer-reviewed research articles and book chapters. He's founding editor-in-chief of the Journal of Obsessive Compulsive Related Disorders and serves as the editorial boards of several other scientific journals. Dr. Abramowitz is a scientific and clinical advisory board member of the International OCD Foundation and a past president of the Association for Behavioral and Cognitive Therapies. He has received numerous awards for contributions to the field in OCD and clinical psychology, and his mentorship of students and trainees. His books include Living Well with OCD, The Family Guide to Getting Over OCD, and Getting Over OCD. The second edition. And lastly, he's another book, Exposure Therapy for Anxiety. So without further ado, here is my conversation with Dr. Abramowitz about postpartum OCD. All right, Dr. Jonathan Abramowitz, thank you so much for joining me again today for the Fearcast to talk about postpartum OCD.
You bet, Kevin. It's always a pleasure to be here.
Awesome. Well, I had you on last time, and I'm so appreciative to have you on this time. And you dropped that hint at the end of our last chat that one of the things that you're interested in doing, or one of the things you've interested in research, is postpartum OCD. And I think that's one of those areas of OCD land that isn't talked about a whole lot. It exists. I know we have talks about it at the IOCDF conference and elsewhere, but it doesn't quite get as much conversation. So. And with Mother's Day coming up, I really wanted to put this out there for folks who might be struggling, might have those questions, might have those thoughts, and should know that they aren't alone.
Yeah, definitely. So can we talk about what it is? Where would you like to go?
Let's start at the top. Let's talk about just what is postpartum OCD for those who may not know what it is.
Yeah, so we know that there's kind of a spike in the age of onset of OCD, particularly among women in the 20s. And one of the reasons for that is that there tends to be a higher incidence of onset of OCD among folks who are pregnant and in the postpartum. And so it's, kind of most straightforwardly, we're talking about, the definition of postpartum or perinatal OCD is that it's OCD that seems to start during the postpartum or during the perinatal time, which is, pregnancy and after childbirth. And there is a certain profile that the symptoms, the obsessions and compulsions in postpartum OCD tend to focus more around the newborn. So we don't see as much like, symmetry and ordering rituals or like, contamination from asbestos or things like that, unless it relates to the baby. We tend to see more thoughts about, what if something bad happens to the baby? What if I do something harmful to the baby? So that can be contamination. It can be, what if I make them sick? It can be, what if I harm them? And so, the typical rituals that you would see, often checking, sometimes there's avoidance, sometimes excessive cleaning. We've worked with folks that, if they're bottle feeding the baby, they'll spend extra time cleaning those bottles to make sure they're perfectly clean. But that's what we're talking about, OCD that seems to onset or worsen around the time of pregnancy and childbirth.
Yeah. I appreciate that last little addition there as well, is that it can start around childbirth, but can also tend to worsen around childbirth. So it's a subtype that can manifest on its own, can manifest as the diagnosing or the symptom that led towards a diagnosis, but it can also be someone who has had OCD in the past, and then it kind of manifests differently in this new way based around the child.
Yeah, that's exactly right. And, there's not a diagnostic class called postpartum OCD. We just kind of have that as a nickname that we kind of use because, as we were talking about before, in the OCD community, we tend to label, this kind of OCD and that kind of OCD. So it's not an official diagnosis. It's not in the DSM. Postpartum OCD, like you do have for postpartum depression, that is a separate diagnosis.
Its own thing.
It is. But in OCD, we just call it that because, like you said, it either worsens or it onsets. And there are people who they've never had OCD, and then all of a sudden, at some point during their pregnancy or after childbirth, boom, they develop OCD kind of out of thin air.
Right. Yeah. And, to some of those folks out there who might now be experiencing it or have a spouse or a family member who's now experiencing this, it's not that now they're worse or now they're sicker, now that they've developed another, quote, another OCD. It's that they continue to have OCD or now they have OCD. And then we've just called it this subtype, which is helpful in Googling, or it's helpful in knowing that there's a community out there that, the thoughts you're having, the experience you're having isn't unheard of. There is a community out there for you that shares your struggles. And it's just a shorthand for us. So we know it's not hand washing. It's not existential OCD. It's not your faith. It's about your child and usually harm towards your child.
Exactly. 100%.
Right. Off the bat, you mentioned the differences between postpartum OCD and postpartum depression. Can you draw the difference between those two for people who may be curious about the differences?
Yeah, it's a great question, especially because sometimes they're confused for one another. Depression involves thoughts that are kind of overly negative thoughts about the world, the future, yourself. So like, I'm terrible. I'm no good. The world's a terrible place. I'm hopeless. Things are hopeless. And, there might be shifts in the content about what the person's sad about, but generally speaking, there's more sadness and not so much, fear of something terrible happening. And you don't have compulsive rituals in depression, postpartum depression or otherwise. OCD, the fears tend to be, more specific. Something terrible is going to happen to the baby. I'm going to be responsible for the baby. I didn't do enough to protect the baby. And often the person gets kind of, as we know, they get stuck obsessing about, some particular things. The bottles aren't clean enough. Or what if I lose control and, stab my baby? Or what if when I was changing the baby, I had a sexual thought? And it's not general sadness, but it's more fear. And it's more about, I have this desperate urge to get rid of this fear, to escape from this distress. And so that's where compulsive rituals come in. And while we're on the topic, we should also talk about the difference between all of that and postpartum psychosis.
Great.
Is that okay? Yeah.
Let's do it.
Let's do it. So there are people who experience psychotic features, so delusions, hallucinations in the postpartum. This is extremely rare, extremely rare. Like we're talking 0.1% of new moms who experience this. Meanwhile, postpartum OCD, the rates are as high as I've seen 5 to 9% of new moms have OCD symptoms. So, not uncommon whatsoever, but postpartum psychosis is very, very rare. And what happens here is people have hallucinations and delusions, and that's different than obsessional fear. So they might have content. The content of the thoughts might be about, harming a child or harming someone else. But in psychosis, the person is not afraid. They really believe it. They believe that it's true.
It's a fact.
You can't.
Yeah.
That it's a fact. Yeah. So and usually these are very, very bizarre. I saw smoke coming out of the baby's ears, and so they must be possessed by the devil. So very, beliefs like that, different than OCD. However, unfortunately, we see even mental health professionals that sometimes they'll hear about someone who has postpartum OCD. They'll describe postpartum obsessions. I have thoughts about, what if I harm the child? And they confuse it for, oh no, this person has psychosis. And it's just, if you really understand OCD and you do a good assessment, it's not that difficult to tell the difference between the two. The most important difference being that people with OCD do rituals. They have a fear, and they do rituals because they, at some level, they recognize these thoughts are senseless. This is not me. Whereas in psychosis, the person really, really has this very strong belief. And sometimes in OCD, you can have an obsession about, well, what if I have psychosis and what if I believe it really strongly? But again, that would be suggestive of OCD. People who have psychosis, they don't worry about having psychosis.
Yeah, I kind of explain this, that kind of the differences there between, and I think I stole this from Grayson, is what I call the insensitive OCD joke. It's what's the difference between someone with OCD and someone who's crazy, is the person with OCD knows they're crazy, in that they have this kind of these two sides, this feared side and this this rational side. The person who's the person, someone with OCD has both. They go, this sounds so crazy and so awful, but it sounds so crazy. But they have the thought. The person who has the psychosis, they don't have that rational side that says, I know this isn't real, but boy, it's scary. They say, this is my reality. Smoke is coming out of that baby's ears, and this is awful.
Yeah, exactly.
So,
Exactly.
a tremendous difference, but an important one to point out, because I think there are going to be some folks within the postpartum OCD world who are then going to have a secondary fear. Well, what if it's not this? What if it's this whole other thing?
Yeah, and you read about, Andrea Yates is the classic case from like 25 years ago. Mm-hmm. She had psychosis, not OCD. She had thoughts about drowning her kids, and she did drown them. She believed they were possessed, and she has subsequently been found to have psychosis, not OCD. But boy, after that case, we had people coming to our clinic. I'm the next Andrea Yates. I've had thoughts about drowning my kids, and they were clearly OCD because they were able to say that.
Yes.
Right. If you're afraid of doing it, then, again, much, much, much more likely to have OCD.
Right. Yeah. So I'm assuming, because we've addressed this, no one who's listening to this will ever have that obsession, will ever have a concern about it. So we can all thank Dr. Abramowitz for setting everybody straight.
As soon as I open my mouth, I worried, oh no, we're opening a huge Pandora's box. But you know what? It is important to be, to understand and be knowledgeable about this kind of thing. So, hopefully this kind of helps to set the record straight. But if you have doubts, it is okay to have a consultation with a professional if you haven't done that. But it's a tough area because you do have folks that are like, oh no, you said this and that made me have a new obsession. So I apologize if that happened to you, but it is important to have this information. I would rather get that out there so that people are, so people are knowledgeable.
Absolutely. And all joking aside, and by the way, I've 100% gotten those emails saying, because I had an episode on this.
Yeah.
Okay, now it's like, well, you're welcome. I don't know. This is what OCD does. It grabs onto this new thing. What if I now have this terrible, terrible thing? Anyways, we're sidetracking ourselves perhaps.
Yeah, right. But that's the disorder.
That's the disorder. That's how it works. So, all right, so we've talked a little bit about kind of the differences between all of those. Now, can there be an overlap between postpartum OCD and postpartum depression?
Yes, there is. And in fact, we just finished a 5-year study, just finished within the last year. And we know that absolutely is the case. The majority of folks who have OCD in the postpartum also have some symptoms of depression.
Yeah, I think I'd say that's my understanding when I work with someone with OCD just in general. If I see someone with OCD, I'm going to see someone who has depression. I think someone else smarter than me said this. It's anxiety provoking to have depression, and it's really depressing to have anxiety. So
yeah, exactly.
We're going to see them together.
And here you are at this time in life that's built up as you have a baby, you're supposed to be really happy, but no, you have all these intrusive thoughts and avoidance and fears and anxiety, and that will lead to depression. And as a parent, my kids are older now, but I can tell you that it's not the happiest time to have babies in your life. It's very stressful.
It's very stressful.
That's a normal thing. Yeah.
Yeah. And I think I love that you acknowledge that as well. The amount of stress, the amount of difficulty going through it is incredibly stressful. And there are going to be times, I think this is more of just a normalizing process for anybody who may be struggling with this, is that, every parent is going to tell you this, but nothing will prepare you for that, for being a parent. OCD aside, depression aside, nothing's going to prepare you for it. So then tack that on to OCD that's going to then say, no, you're different, you're special, you're weird, you're bad. These are above and beyond. And you're responsible, right? That seems to be a big thing. Here's this helpless baby or unborn baby, right? And you are responsible for it. And you could mess this up. And OCD loves to kind of latch on to that fear. The responsibility part. I can do this and I have to do, and that's where the compulsions come in. It's incumbent upon me to do something about it. So where does, in your research, has anything come out why one person has postpartum obsessions versus other types of obsessions? Well, yeah, we didn't compare regular OCD to postpartum OCD. Okay. What we looked at was, we had over 300
no, close to 300 new, expecting moms. We recruited at UNC in Chapel Hill, North Carolina, and also in Baltimore, Maryland at Hopkins. It was a collaborative study. And we followed them through 6 months after childbirth. And half of the sample, we recruited them because they were elevated on some factors that in the past, research has found to suggest that they're more vulnerable to developing OCD. And we wanted to test that out in a big sample. And then the other half were folks that didn't have those vulnerability factors. The vulnerability factors were the tendency, like we were talking about, the tendency to inflate responsibility, the tendency to overestimate the importance of senseless intrusive thoughts, the tendency to overestimate risk, and be intolerant of uncertainty. And it turns out that folks who even they've never had OCD before, or maybe they had some symptoms, the people who were in that group and then went through childbirth, they were more likely to meet diagnosis for OCD. They were more likely to have more severe symptoms. Those people who didn't have those vulnerability factors.
That's a good thing to certainly keep aware of for someone out there. If you're listening to this and that's a characteristic that you share, maybe something to look out for. Not to say that there's a magic trick you can do to then make sure it never shows up, but that may be one of those things that could show up.
Well, that's right. And what we have also done in a previous study was develop a program that seems like it could be helpful to prevent OCD in the postpartum. What we did, this is about 10 years ago, working with actually the first author on the paper is Chiara Timpano, who's at University of Miami in Florida. And she she developed a program where we had folks who had these risk factors, so these obsessive beliefs, right? These cognitive kind of styles of overestimating risk and all that. And half of them, we had like 100 of those folks, half of them we educated about just kind of OCD in general and mental health in general during their perinatal education classes. The other half received an intervention similar to CBT for OCD. We didn't do exposure and response prevention. It was more the educational and cognitive therapy side. So, you are going to have intrusive thoughts because all parents have them. We know that all parents have them. Plenty of research shows that. You're going to have unwanted thoughts about your kid. You're going to have thoughts that something wrong. Here's how to understand that. Here's how to see this for what it is. It's normal. It's you being a caring, sensitive parent. It doesn't mean you're mad, bad, or dangerous. It's just thoughts. And we found that, lo and behold, the folks who got that intervention, they had less OCD symptoms in the postpartum than people who didn't get the intervention, who just got the general education about mental health.
Interesting.
So that was really cool. Yeah.
That's really fantastic. Is there a place that some parents to be could find that information, or is that go ahead.
Yeah, if you go on Google Scholar, which is free, anyone can go to Google Scholar. And if you type in, I think the paper came out in 2011, Chiara Timpano, Timpano, and colleagues. And Kevin, I'm happy to send you a copy of the paper. And if you want to, post it or a link to it or something like that, you can certainly do that.
Let's do it.
We want to make this stuff, as widely available as possible. In the article, we don't have the actual manual of the education program, but we have a description of what it was like. And, certainly, that's a good start.
That's an absolute great start. So, yeah. And that's the whole point of this podcast and, stuff that both you and I are doing to try to get good information out there into the hands of people that need it. So that's awesome that program exists. What role does hormone changes in pregnancy play in the development of postpartum obsessions?
Well, we're looking at that too. So one of the things with this most recent study was we got blood, we got spit, we got urine, all sorts of bodily fluids.
Intentionally or unintentionally?
Intentionally. So we collected specimens from these pregnant women, and we are currently looking at the data and analyzing them. I'm a psychologist, so I don't do a lot of the biological side, but what I have learned is that biological data analysis is really complicated. There's a lot of moving parts to it. And, part of the problem is that our hormones, our, biological systems, they're changing all the time, right? I thought it was going to be as simple as, well, the people who have the high hormones, they should develop OCD. But it depends when you measure the hormones, before you go to bed, when you wake up, after you've eaten. Mood can change hormones and other, neurochemical, kinds of things inside, biological factors inside the body. And so we try to control for that. But it's really, the idea that, well, hormones cause postpartum OCD or serotonin causes, it's just not that simple. It's just more complicated than that. And we don't understand it very well because it's really difficult to understand.
Totally. What's going on in my head is, who would have thought that we were so complicated people? But it's, the joke aside, it's like, I appreciate you kind of addressing this, because I've read some stuff, heard some stuff that talks about the hormone changes and how that can lead to, and so it sounds like just that it's not as easy as just simply say, because of the hormone changes, that's why postpartum obsession shows up. So
it's definitely not that simple. And what's really interesting is some research that we did, again, years ago. We found that expecting and new dads also can develop OCD symptoms in the perinatal, and when their partner is going through perinatal and postpartum. And what that suggests is it's got to be more hormones, because the dads aren't having changes in progesterone and estrogen, as far as we know. What my feeling is that, does biology contribute? Sure. You have to have biology to have OCD, and in some way that I don't think we understand. Maybe our study will help us. Maybe that's playing a role, but I think that what's more important is the person's environment, their psychological, maybe their learning history, their cognitions, the tendency, as we were talking about earlier, to overestimate responsibility, overestimate threat, overestimate the importance of thoughts, overestimate or have an intolerance for uncertainty. It's those factors that probably account more for OCD than any biology.
So important. And I love that you got ahead of me on that. I was going to ask, what do men, I kind of know the answer to this already, do men experience postpartum OCD? And then do you know rates on it, or do you know any trends that tend to occur within the male expression of it?
Yeah, they do. And we do know about that. So I'll just give you a quick study, a quick story, because
yes, please.
The way I got interested in this was I had a newborn. My wife actually had the baby, but and one night
you played a role.
We were taking. Say that again.
You played a role.
I definitely played a role. I'd like to think. And one night, I'm up giving the baby, a bottle in the middle of the night. My wife's sleeping. We take turns, feed the baby. She's like, a couple weeks old. And what do you do after you give a baby a bottle? You burp the baby. So I'm sitting there burping the baby, and the thought goes through my head, what's stopping me from just rearing back and beating the heck out of her? I love her. I would never do that. Now, I don't have OCD, and I study this. So the first thing that went through my head, because I'm a nerd, was, oh my goodness, that's like an intrusive thought. And I'm not going to interpret that as dangerous. I know exactly what's happening. This means I'm a good dad and I care, and I'm not going to avoid. I'm not going to do any rituals. Not going to ask for reassurance. I'm going to keep burping the baby, and I did. But the other thing that I did was I had some friends that were going through childbirth at the same time, dads, and I asked them, "You guys ever think about?" And one was like, "Yeah, I think about. What if I stuck my finger in the baby's soft spot?" Yeah, right. which is not an uncommon one.
Yeah.
And another person had the same thought about burping, and someone had the thought about, my baby's a girl, and what if I was staring too much at, between her legs when I was changing her. So we did a study on this because that's what nerds do. We did a big survey of like 300 people. This was back when I was working at the Mayo Clinic in Minnesota. And we found that like 70 to 80% of new dads reported that they had intrusive thoughts. Some of them did rituals. Some of them had OCD, like in the aftermath of their baby. It's not a huge amount, but it is definitely there. And again, what's most interesting to me about that is that this means that biology probably plays less of a role than sometimes we want to think.
Yeah. Oh, I appreciate that story. For those of you listening to this and not watching this, if you're watching it, is this, I had a very similar experience with my kid in the first, a couple of weeks of having a child, and you're trying to figure them out because, you don't know what buttons to push. Not the soft spot. Don't do that. But it was, it's 3 a.m, inconsolable. I've done all my tricks. I bounced on the ball. I've done the thing. I did this big move that I used to call the pachyderm. You hold them kind of arms straight out like this over, and you swing them back and forth like this, like they're on your trunk. So I did all the things. They're still crying, and I had the thought, what if you just shook them, shook them real hard? And I also was working with OCD at the time, and I don't have it, and I went, how weird. This is how, if this was a thing for me, I could certainly see, why do I have this? I'm in an emotionally vulnerable state as I'm exhausted. I bet my brain could latch onto this like someone else did. And I went, interesting. And then I kept going and let that thought pass through. But yeah, it is something that we have. And I don't think certainly, yes, for men, but I think certainly for women, these are not thoughts or feelings or concerns that are openly discussed because of the fear. If I say that with my newborn, because as you said, you're supposed to be in this just loving, glorious phase of my newborn and how beautiful they are and just basking in it. And you know what? It's hard. So if you have this violent thought, or the sexual thought, or fill in the blank that's not what you're supposed to, you're bad, you're awful, you're terrible, and so what do? Stuff it.
Yeah, that's right. And that contributes to the fear because you never get that, talking to other people, oh yeah, I have that too. And that Jack Rackham, who's like one of the godfathers of OCD research, would talk about and write about the concealment of obsessions. When people go out of their way to hide their unwanted thoughts, that's kind of like avoidance. It's kind of like doing a ritual. And it really does feed into the fear. It's like, this is so bad, I can't tell anyone. And so it just kind of reminds the person to misinterpret their thoughts. Exactly.
And because you didn't receive any, you didn't get that criticism, that rejection, that whatever, it proved if I keep it silent, nothing bad happens.
Everything's okay. That's right. Yeah, right. And then when you don't go harming the baby, it's because I didn't talk about this. It's because I avoided. And that's the way that OCD works. It kind of draws you in.
Exactly. So, all right. Well, in the sake of time, we might as well talk about what treatment looks like for it.
Yeah. Well, it's the same as usual. Exposure and response prevention is the way to go. And people can learn that these thoughts are not anything that I need to be concerned about. And I don't need to try to resolve them or fight them. And I can still be a good parent even when they're there. And I like to talk about how we help people to change their relationship to their thoughts, to their anxiety, and see that they don't have to get into a struggle with those things. Through exposure and response prevention, you learn not to be afraid of them. And that is really our best treatment. And it's, often very effective. There are some smaller studies of ERP for postpartum OCD in particular, but we've got hundreds of studies, showing that this therapy works for OCD in general. Medications can be helpful. There's some folks are concerned about, Do you take medications when you're pregnant? Do you take medications when you're breastfeeding? From what I understand, there's a very low risk, but there are people who would prefer. Some people, swear by medications. Some people would prefer to not have them at all.
It is so surprising, having gone through the whole parenting thing, still going through it, that how little they know about pregnancy.
Yeah.
It's alarming. That's a separate conversation, I suppose. So to shift back, I'm curious about, since a lot of clinicians also listen to this podcast and will want to know about different ways to do it. I feel like there's a little bit of a debate with therapists about the cognitive restructuring, the cognitive piece of CBT, and to what degree can we go through that where it's informative, it's normalizing. That doesn't cross the line into the dreaded 4-letter word of reassurance. Because hearing, gosh, we all are going to likely have violent thoughts, harmful thoughts, weird thoughts, crazy thoughts. That can be very assuring and reassuring for little r reassuring. Where does it? What is it that in your research or your experience treating this, feels that we can confidently say and confidently assure versus where it starts to become inappropriate and beyond the pale?
Yeah, it's a great question. I think that giving some initial psychoeducation, where you're kind of showing the client, the patient, here are some facts that we know, and we're going to move forward with these facts as a given. Mm-hmm. But we're not going to talk about them every time. So, we're not going to answer questions about, are you sure this is normal? Are you sure this is normal? We're going to kind of lay these down as the facts. I tend to stay away from cognitive therapy, like the Beck and Ellis, like thought challenging stuff. I tend to stay away from that with OCD. I wouldn't say I never use it, because that's a really strong word, but
yeah,
I do get concerned that it can really quickly turn into reassurance seeking.
It absolutely can.
But I also think that there are two things. Number one, I don't think you can talk someone out of OCD. Yeah. And number two, I think that experience is the best teacher, and experience is the best cognitive therapy. So exposure and response prevention, where you're leaning in, let's give the baby a bath. Let's think about drowning him. Let's think a sexual thought while you're washing the baby's crotch. Let's hold the baby and look at the soft spot and think about, sticking a fork in it or something like that, and learn that you can think about those things. It's not dangerous to think about those things. You're not going to do anything terrible. And, most importantly, those thoughts are things that you want to be friends with. You want to allow them to come along for the ride, because they're not going anywhere. And the more you try to fight them, the worse they're going to get. So we need to change the agenda.
I'm hearing in that a lot of inhibitory learning model components of learning that we're not habituating to these thoughts or getting used to them or getting happy or good with them. We're kind of as you said, we're learning that these thoughts can occur alongside your good parenting. These thoughts can occur, and you can be present and attentive and loving and all those good, wonderful things. And inside, you can have these very antisocial, quote, awful thoughts that mean that you're a human with a human brain.
100%. There's elements of inhibitory learning. There's elements of ACT in there, which I think there's a lot of overlap.
Oh, yeah.
But yeah, I agree. I love what you just said, 100%.
Do you ever do scripting with folks? Or is that, I know scripting is a controversial step these days.
Well, it shouldn't be, because all we're doing is we're helping people take the thoughts that they already have in their mind, and we're helping them to be able to experience them in a healthy way and develop a healthier relationship to those thoughts that are already there. So I don't think you need to go and make up all sorts of, horrifying thoughts if the person doesn't have them already. Although I don't think that that's going to harm anyone anyway, because our minds are not who we are. But I don't think it's controversial at all to sit and help a person to learn that they can think about whatever And that's the wonderful thing about being human, right there. It's legal to think about anything.
Yeah.
Now, doing stuff is a different story, but just because we think about it doesn't mean we're going to do it. And it's important for a person to learn that, right? Your thoughts are not in charge of what you do. You are. And so, I do. I sometimes will, if the person has like, I get this terrible story that I'm taking the baby for a walk in the stroller, and I get the thought of like pushing her into traffic, and the cars are hitting the stroller, and boom, boom, boom. Yeah, we'll write that out. Absolutely.
Mm-hmm.
Why not? And listen to it on, your AirPods while you're going for a walk to see that it's safe to do that.
Yeah, and it's not the amount of the frequency of these thoughts that show up that make it more dangerous. I mean, sometimes some kickback from some folks with these obsessions are going to be, gosh, if I have these thoughts, if I have more and more and more, I might likely do it, because don't you know the people who do it, don't they think about it?
Yeah, exactly.
Right.
Yeah, and so it's easy to kind of confuse that, and that's where are we capable of doing these things? Yes. I was certainly capable of slapping my kid, my 2-week-old, across the back, because I have muscles and I can do that. But still, I get to make the decision, and we know that folks with OCD, they're the last people who are going to act on their thoughts. In fact, they're so afraid of behaving badly that they're afraid to think about.
Oh, I love that saying.
Yeah. So we want to teach them that they don't have to be afraid of thinking anything. I think we ought to teach everybody from the time that they're 5 that it's okay to think about anything.
I love it. I love it. Yeah. I mean, we give the Stephen King example, right? It's just, if he has a terrible, horrible thought, he doesn't say, "Oh no, what does it mean about me?" He goes, "Oh great, I'm going to make another $1 million."
Exactly. That's right. Well, and think about, doctors who think about illness all the time. Think about police detectives who think about all sorts of terrible, stories and violence and all these things. And writers, like you said, and actors who are acting out, terrible parts of murderers and rapists and stuff like that. Yeah. Our brains can be bullies, and they can give us all sorts of thoughts. And we want to learn how to stand up to that bully instead of getting pushed around by it.
Exactly. If the people who are going to do it, if simply having the thought meant that you were going to do it, then researchers like Dr. Abramowitz would be more likely to do it, because it's his full-time job to think about this. I would have
already killed lots of babies and... Exactly. That's right.
Exactly. So we can have these thoughts, right? And as we go forward in life, we're going to learn that we can have these thoughts, and addressing that moral component. We've already talked about this, but sometimes there's that moral that moral obstacle. Well, isn't it bad to have these thoughts? I want to be a good mom. I want to be a good dad. I don't want to be intentionally having these thoughts. How do you address that with someone who may have that as one of their obstacles?
Yeah, well, again, there's a difference between, thinking about something and doing it. And, if you ask, think about the most moral or the most pious person they will tell you that they have also had thoughts about doing terrible things. They might not wear it on their T-shirt. Mm-hmm. I'll often, say to folks, what do you think about me? Do you think I'm a decent guy? Yeah, you seem decent enough. What if I told you that I had thoughts about, harming my newborn, or, doing other sorts of things that I won't even say on a podcast, because I have had all those thoughts. Yeah. Because we all have, would you think of me any different? Well, the person says no. So, well, why is it different for you? And people often have a double standard. Yeah. And so, learning about being able to understand and kind of have faith and confidence in yourself that it's okay to think about anything. And it's not always pleasant to think about everything, but there's a difference between, I don't like this thought upsets me, versus this thought is dangerous, or it's some sort of call to action that I need to take some sort of precautions about.
Right. And it's practice. It's practice, and as you give yourself that permission to have that thought, and you can do that, within the quote controlled environment of therapy, and just giving yourself that small permission within the room of therapy.
Yes.
You can slowly start to apply that to your regular life or outside the office. And again, doing what we're talking about here. So, I think that the goal for today in this was just to talk about what postpartum OCD is, how it works, what treatment can look like, and also to offer some encouragement to, parents, new parents, old parents, whatever it might be, who might be going through this, that you're not alone.
I do want to point out one thing that you said that I think is really important that you kind of hinted at. Exposure therapy is not something where you just kind of say, oh, I should just expose myself, so let me write this script or let me go do this. You do want to do it under the supervision of a therapist. Mm-hmm. And that could be over, Zoom, it could be in person, but exposure works when it's supervised, when it's very systematic. And you got to do it the right way. So a lot of people come in and say, well, I'm exposed to this every day. I think about this all the time. But it doesn't work. And no, of course not, because you're not really doing exposure. You're probably fighting the thoughts. You're not doing response prevention. So it is important that before you do this, or when you do it, that you do it with a therapist. And like you said, Kevin, starting in a controlled environment is really important to get the hang of it and see that thinking about stuff that you don't like is not as terrible as you think. And then with gradual practice, you get better and better at it.
Right. And I'll again point back to you is that response prevention part, right? A lot of people will do these things. They're doing exposures and they're like, yeah, I'm giving my kid a bath every week. We're going for walks. What's the problem? It's that oftentimes in their head, they're saying, I'm okay. I'm a good parent. They're having safe thoughts. They're doing prayers. They're doing something to try to quote, make it safe. Whereas,
maybe their partner is supervising that I'll give a bath, but only if you stand over my shoulder and make sure I don't do anything wrong.
Right. It's that we're trying to pull back on those, and that's where we really learn that I can do this. Right.
That's where a therapist comes in handy.
Right. We've done a ton of episodes on response prevention, and you can listen to pretty much any episode of the Fearcast or anything that Dr. Abramowitz has written, and it'll outline more of what response prevention looks like, and that's what we're trying to do in the context of this. So, I mean, in the meantime, I mean, if there is one piece of advice, one piece of encouragement that you would offer to someone, who may be going through this or have a loved one who's going through this, what would you want to say to that person?
Yeah, a few things. First is that it is normal to have unwanted intrusive thoughts in the aftermath, during pregnancy and the aftermath of giving birth. Mm-hmm. It's just like good parents think about bad things that can happen to their kids. That's part of being a parent. So be open to that. Be willing to have those thoughts. They're part of the whole deal. If you're having trouble with those thoughts, you feel like you're getting into a struggle with them, they're making you avoid stuff or doing rituals, and maybe it's coming between you and your partner, you're having trouble bonding with your kid because you're avoiding it, help is available. Find someone who has expertise in exposure and response prevention for OCD, seek them out. There are lots of, the IOCDF is a great resource, but nowadays you can find clinicians online. You can hopefully find someone in person as well. And it's a challenging therapy. It takes a lot of work, but boy, is it worth it. When you do it well, the likelihood of learning some really important stuff and having success is really, really high.
Absolutely. So thank you so much for saying that. And so, information is out there. I know the Fearcast podcast website has a bunch of links to things. IOCDF has just more information than you'll ever be able to access. So check it out if it's out there. So, Dr. Abramowitz, thank you so much for joining us for today. And if there are questions in the future, would you be willing to hop on and answer some questions?
I would be. Thanks for having me. It's always a pleasure chatting with you about OCD stuff.
Awesome. Well, thanks so much.
All right. Take care.
Thank you for listening to the Fearcast. If If you would like your question answered on a future episode, please click on the Submit a Question link at fearcastpodcast.com. If you would like your question answered sooner, please send me a recording of your question to questions@fearcastpodcast.com or by sending me an audio message through Instagram by DMing me at fearcastpodcast on Instagram. If you like the Fearcast, please write a review on your podcast platform of choice. Please remember that the Fearcast is not a substitute for psychotherapy. If you need a little bit of help in your recovery, please go over to fearcastpodcast.com and click on the Find Help link, and there's going to be some information for you there. So until next time, take a risk, challenge yourself, and don't take your brain too seriously. Bye.